So what's going on? Where's everybody right now? Where's everybody on this particular group here? Where's everybody at right now? I know Vanessa is in Cali. Maritza, you're in
Antigua.
Antigua. What about everybody else here?
I'm streaming from San Cristobal in Venezuela. This is the border with Colombia.
Okay.
I'm gonna be one of the guys in control here.
I'm in Paraguay right now.
In Paraguay, okay.
I am in Caracas.
In Caracas, nice, okay.
People from Costa Rica.
Sí, díganos de dónde vienen, escríbanos en el chat, de dónde nos escuchan, para que ahí sepa.
Okay, welcome everybody. Bienvenidos sean todos para la reunión de la Sociedad Venezolana de Oftalmología el día de hoy. El Grupo Venezolano de Glaucoma los invitamos para hacer esta presentación con el doctor Ahmed, Out of the Comfort Zone with Ahmed. La doctora Vanessa Vera y yo seremos las moderadoras y el doctor Alexander Gang nos va a ayudar el día de hoy a colocar todos los tips en español que el doctor va a ir diciendo en su presentación en inglés para tener más información. Entonces, tenemos que presentar a esta persona que no necesita presentación, pero lo vamos a presentar. Y esto lo voy a decir en inglés porque quiero que el doctor Ike lo escuche. Welcome everyone. For me, it's a dream come true to present this giant of ophthalmology, Dr. Ahmed. He is the second most important and influential ophthalmology in the world by the Journal Ophthalmologist 2020. What is most impressed for Dr. I is not all the awards he has in his career. What is impressed is the extraordinary personality, humble and incredible human being with incomparable talent. What made him spectacular is his passion, dedication, and discipline. He always pays attention to how patients feel and always credit the team for the great result. Thank you, Dr. Ahmed, for staying with us tonight. Thanks for answering the email. Thank you so much. I will stop sharing the screening for you can share your screening, okay?
Thank you, Maritza. Thank you so much. And thank you to all of you for attending here, especially Maritza for making this happen. Vanessa, of course, familiar face, and all my colleagues here from Venezuela. And also, I know many of you are from around the world. So it's great to be here. And I'm going to just share my screen to get started. I did want to say a few opening remarks. And this is going to be a pretty wide discussion. Lots of different things that we can talk about. And I'm hoping that it'll be something that will be of hopefully interest to you. I know that there's some question and answers as well, or questions that may come up. So I'm going to rely on the team, Vanessa, Maritza, who else is there? Alexander, Sigfrido, right? All of you. If there's any questions, let me know, right? But the topic is out of the comfort zone, which is a place where I like to be usually. In fact, for me, it's uncomfortable to be comfortable, believe it or not. But I know this is a different way to think about things. And I'd like to share with you some different ways to think about glaucoma. Before I go there, though, I want to just show my disclosures as usual. Hopefully, I won't be too biased. So let me first thank Maritza for inviting me. One thing I've learned from two Venezuelans who I know, both Maritza and Vanessa, is how persistent they can be. And I have not seen that kind of tenacity and resilience in many people. And I don't know whether it's coincidence. Maybe it is, maybe it isn't. But I met Maritza, I think, a few years ago at a meeting at Academy, and she wanted to come and visit. And I think she emailed me a few times, and I ignored her, as I usually ignore people. And she basically kept on persisting, but I didn't really respond, I guess. I don't remember, actually. And then she came to Canada to visit for a meeting. And then she basically confronted me at a meeting I was actually chairing in Ottawa. And she said, I'm going to come and see you. And from there, she came and visited. And it was quite a visit. It was nice. She was a little first disoriented at first. We made her feel very welcome at home. And so this is the way we typically welcome our visitors. But she definitely made quite an impression, quite a splash with everybody. And it was her passion and her zeal and her energy, which was really incredible. Although she said I was bullying her. She said I'm bullying her. Like, really? I mean, she said I was a bully. I had to be careful. And of course, there's Vanessa, my beloved fellow from a number of years ago, not too long ago, not too long. But Vanessa also came from quite a circuitous route. She was, I was at the Curso meeting in Bascom Palmer. Remember that, Vanessa?
Yes.
And she was sitting in the second row, and I gave my talk, and she came up afterwards with her preceptor, right? And
Yep.
basically we were talking, and she was saying she might visit, and I said, okay, whatever. Yeah, people say they visit. No one really means it, you know, whatever. And then she ended up coming to visit eventually. And when she visited, it was an observer, but we were so impressed with her that we suggested maybe she should think about applying for the fellowship. And she did. And she came for the fellowship. And then in the middle of the fellowship, or near the beginning of the fellowship, she had the decision to make whether to stay or not. And she ended up staying. And she ended up meeting her husband now in my operating room. So I basically matched them up. And it's really not an easy thing to come from a foreign country and live in Canada. And she was incredible and amazing. So this was actually recently taken in the days before COVID, actually just before COVID. We have the two Venezuelan stars here, Vanessa and Maritza, along with some of our team and our nurses as well. And happy International Nursing Day, by the way, for all our nurses that are with us. So it's been quite a ride. And it was quite a special moment to see the two Venezuelans. I must say that I usually feel I can control people pretty well, but I know I cannot control Venezuelans. Vanessa was probably the only fellow who really was shouting at me and telling me what to do for the fellowship. So that's unusual, but that's Vanessa. And I think it's her Latin flavor, but I think her Venezuelan tenacity, right? You know, so I do send greetings to all of Venezuela, and you guys, you are really strong, amazing people. I've only met a few of you, of course. I've met a few new friends as well, and everybody. I mean, I'm so impressed with the spirit that you have in your country. But I'm going to talk about being uncomfortable, and we all have our comfort zone. But if we really want to make things happen, we have to really be willing to be outside of our comfort zone. And this is a slide I took from a website, just showing where most people are in their comfort zone. Right? You're getting by. You're playing it safe. Maybe putting off big decisions to make. And, you know, that's easy to do. But there's going to be a few people out there who want to choose, you know, to go beyond what's comfortable and be uncomfortable a bit to get the most out of life, to get the most out of your experience, to go beyond the norm. And it's not easy to do that because it means taking some risk. But the greater risk you take, the greater reward there is. And there is risk in failing, but the ability to get up from failure is what defines success. And so I encourage all of us to do that. And this is kind of a quote that, yeah, comfort is beautiful, but nothing grows there. If we want to grow as people, we have to be able to put ourselves in uncomfortable situations and ask ourselves uncomfortable questions. I was going to start here because Maritza and Vanessa asked me to give maybe a bit of a philosophical beginning to this. And then I'm going to get into my top 8 pearls in glaucoma that are controversial, that will make you uncomfortable. And hopefully you'll disagree with me, so that way you'll be uncomfortable by that. And I want to speak a bit about the journey, because I always think about this and reflect about where we are in our lives, in professional life and our personal life. We're all during this COVID era, I think we're really thinking about where we are in life. And this is a view that I used to get used to, but not anymore, is a view from an airplane. I haven't been on an airplane in 2 months. And it's really interesting. But when you're up that high at 30,000 feet, it really gives you a chance to really reflect on things. And you know, we study hard, right? These talks are about the books and about the information. We all learn from our journals. We learn from the textbooks, and that's important. We learn by this method is very important. We learn by watching people do surgery, and we copy them. We try to mimic them. We try to do the same thing that they do to do this. But that makes the possible possible, right? That makes the possible possible. But if we want to achieve the impossible, right, we have to be able to think beyond this and observe more than simply the simple, you know, mnemonics and the simple step 1, step 2, step 3. And I love the quotes from Muhammad Ali, and I have this quote on my top of my desk here at home. Impossible is nothing, and that's kind of a dream. It's an imaginary phrase, but things always start in imagination. And as much as whatever credit I may get, I laugh a little bit because I was voted somehow the second most whatever influential ophthalmologist or whatever that was. And, you know, people who know me, I mean, I think it's really not me per se. I'm very much an outsider. I'm not really into that in that kind of class, and I think there are great people in that class of people. But the one thing I think that I'm not necessarily, I don't think you need to be smart. You don't need to be rich. But if you have that human factor, I think that's the common thing that I see when I think of the great people in the world in science and ophthalmology. Many times they had the human factor and the human spirit, and ego does play a big role in that. And there's no question we have a lot of ego in the room wherever we go and talk about medicine or ophthalmology. And I think it's so important to maintain humility and to remember who we are, because there's no reason to think that one is better or one is more superior than the other, no matter who we are. And I think that the human spirit can drive so much innovation. For me, that's a real ground floor of how we do things, is to tap into our human spirit. Unfortunately, I think for most of us, we don't know how to tap into the human spirit. We don't know how to. I mean, I don't know if I know how to. I don't know. But I know that for me, the journey that I've taken really makes a real impact in terms of what we can achieve. And we have to remember that the journey matters, and how we make that journey and how we apply it count. And don't just go through life, through the usual cycles and be comfortable. Ask yourself tough questions, be observant, learn from others, solve problems, make organization from chaos. Don't keep assumptions, and don't, always think that the answer is so simple, and dig deeper. And so for me, just to make a personal story, for me, it's always been an outsider. And I know that maybe I'm lucky to have great people to work with, and I work in a great place, and I have great people to work with. But I still, even to this day, consider myself to be an outsider. And I always ask myself, why do I think this way? Why do I think I'm an outsider? And I have a chip on my shoulder, I'll tell you that. No question I do, and many of you do. And I think these are the kind of questions that I always ask myself. And for me, it was growing up in Canada. For me, it was being born and raised in a very small city in the northern part of Canada, pretty cold, not like Venezuela, not like Latin America, and very small city, very few people of my origin. My origin is I'm a brown guy. I'm Pakistani origin, born in Canada. I'm a Muslim. There was basically no one like me and no one like us in the city. It's a very small city. And so we knew we were different. I knew, and we were treated differently. I remember I got my boxing skills because I had gotten many fights as a youth. Even on my hockey team, my own teammates would hit me and not pass me the puck, and I was the last guy to be taken on my hockey team. So you feel like shit, right? You feel like crap. You feel like, who are you? Even if you're lucky to be in Canada. And these are often a figment of our imagination. And for many years, I really detested my name. My name was so difficult to pronounce for people in my classroom. And that's even the reason why eventually, when one of my friends called me Ike, I kept it. I said, Ike, that's a better name. I want to keep that name. And I kept that name for many years, but it wasn't really who I am. You can still call me Ike because this is hard to pronounce. But what I realized was that, you have to be true to yourself, and that I came back to my roots as far as being different. And I said, I don't want to necessarily be like everybody else, like I was when I was young. I want to be like Michael or Thomas or whatever, like, just an average Canadian who fit in with people. And it was hard. I can laugh about it now. It was very hard. And all of you have had hardships. But my point on this one is that instead of basically trying to be somebody else, I realized I'm different. I'm going to use that to my advantage and stay different. And therefore, it allowed me to break the rules. It allowed me to say, I'm looking at this differently. I don't believe you. I'm going to do something differently. And being different, I think, turned into an advantage, where instead of me following people, for some reason, people sometimes wanted to follow some of my thoughts, which I thought was kind of interesting and kind of fun. And, I think having the right attitude and the courage and persistence is amazing. And this is what I talked about both Vanessa and Maritza. To me, both embody the courage and the attitude to persevere, to be successful, to have the tenacity. Often it's not necessarily the idea that's a difficult thing to invent. It's the tenacity to push it forward in the face of folks that are saying basically, no, you can't do it. And the indifference is sometimes hard to get through. So those are some of my thoughts. Keep on moving. I always say that, I don't think myself and many people I know are very talented, but I think the hard work can really pay off and do well. So think differently, bring the passion, bring the compassion, bring the energy. That I will tell you. I will not say I'm smart or I'm a gifted surgeon, but I will say I am passionate for what I love. I hope I have compassion for my fellow human being, and I'm wired to think differently and be different. And that's my story. So you can call me Iqbal if you want now, if you wish. So that's the journey. But I want to get into the glaucoma side of things, because this is where, for me, we still have a problem. And I want to emphasize the point that glaucoma and things I'm going to say today, the problem we have right now is glaucoma progression and blindness is still a problem. And no matter what data you look at, even in first world countries, we still see an inordinate amount of people go blind, and they die blind with glaucoma. And these are patients who are under the care of an ophthalmologist. It's different if they're not taken care of by somebody and they're misdiagnosed or underdiagnosed. That's even higher risk of going blind. But these are people who are being followed up regularly, right? 90% of people progress despite having regular checkup by a glaucoma specialist over many years. And we may not believe these statistics, but I think they're true. And I want to just, again, emphasize that we have a problem here to identify it. And there are many reasons for this problem. I often put this slide up. I think it's a great slide, a great paper here written, that there's big reasons why. Under lack of diagnosis, poor compliance, and improperly treated. I'm going to focus on the improperly treated and the compliance issues primarily. But of course, we have a big issue with diagnosing glaucoma. And I think one of the big problems in glaucoma is we have been very passive as a group, as opposed to being active in treating this disease. So I want to talk about these, if we have time, 7 points. I want to say, listen, we need to go beyond the office, right? Checking IOP in the office is so 1985, okay? We need to do imaging more frequently and do it right with the right synergy. We need to be more aggressive with our target pressures. We need to move to laser trabecoplasty. This is now, way overdue. And we need to think about MIGS globally and do it cost effectively. And we'll talk about, again, the modern day bleb and how do we keep these blebs going. And if we have time, we'll talk about tube shunts. So that's kind of a bit of an introduction to what I want to speak to here. Okay, so let's talk about beyond the pressure. So here's what I think. I think if you rely on a single pressure in the office, it's outdated. I'm going to say that right now. I think it's outdated. I think we need to think more about 24 IOP, about peak IOP, fluctuations, measure pressures different times of the day. I think there's a role for water drinking tests and provocative testing. I do believe that. My mind has changed from 5 years ago. And I think home tonometry will come and will be important. Let's think about IOP here. And we think about IOP, of course, on average. We take IOPs in the office. But we know IOP fluctuates, and I think it's that peak IOP, which basically we'll call the risk zone, is where the danger zone is for glaucoma. And we need to identify patients who get peaks, and we need to get these peaks down. We're not worried about the troughs. We're not even worried about the average pressure. We're worried about the peaks, in my opinion. I think the data supports that. However, we know that when we measure pressure outside the clinic, we often measure peaks outside the regular office hours. Okay? And these peaks can be missed if we only check pressure during a regular office time. And this is something to consider when we think about where do we measure and how do we measure IOP. There's a well-known fluctuation that can occur, and often at nighttime when we miss it is where potential peaks can happen. And we've seen studies that show that patients who have more diurnal fluctuation over 24 hours, these patients are at higher risk for getting worse. So this is just something to think about. Now, we've been using eye care tonometry. I realize it's not available around the world, but my point is not to say to use this. My point is just to show you that when we do measure pressures beyond the regular time in the office and patients at home, patients' office pressures may be 18, but in fact, they're actually spiking up to even 40 every day. We're missing these things. So we have to assume that this is happening for many of our patients, and we have to think about ways to get around it. We also know from various studies that long-term pressure fluctuation can be a problem. People who have more pressure fluctuation and peak pressures get worse over time. Big studies like the SIGIS study and the AGES study both show that fluctuation, peak pressures are a problem and a risk for progression. Not even the average pressure is an issue so much as the peak pressure. Now, there is some controversy in this topic. I will agree that some studies have shown that fluctuation is not as important. But those studies are typically patients who have early glaucoma and patients who have higher pressures. In other words, if you have a high pressure already, fluctuation doesn't matter. You're already at risk. But if your pressures are otherwise measured to be on average normal in the office and you fluctuate at different times, different visits, that's a risk factor. So to me, fluctuation is important. So peak IOP, how do we assess it? Well, in fact, the water drinking test actually is a reasonable way to do this. Here's how we do this. Many of you have seen this before. Drink about 1 liter of water over 15 minutes and measure the pressure every 15 minutes. It's easy to do. Anybody can do this. You can do it anywhere around the world and do this. Okay. And the validity of this test is not so much for screening, but it's basically to look for the outflow facility and the risk of patients who may have high peak IOPs. There's a lot of reasons why we get IOP elevation when we do water drinking tests. These are some of the reasons why. Think of it like a stress test for outflow. And if our trabecular meshwork outflow system cannot handle the water load, then the pressure will go up in the eye in the immediate time after the water drinking test. We can look at the rise of the pressure. We can look at the absolute peak. There are different ways we can look at the decay of the IOP after the peak. These are different ways we can report peak IOP during water drinking tests. The problem with water drinking tests is we don't have a guideline as far as what's normal and abnormal. So instead, what I like to do, I like to look and see what the actual IOP peaks to. And is that pressure itself above target? Is the absolute peak pressure above target? If it is above, for me, that's a concern. I have to do something about it. I have to address it more importantly. And I won't go through all the studies, but I think there's some good studies, and I have to really credit Remo Susana, who I think has really led the charge with the water drinking test. I was not convinced earlier in my career. Now I am, certainly. And people who fluctuate with peak pressures above 18, for example, and otherwise patients who are otherwise, quote unquote, in normal pressure ranges are more likely to progress. How do we use this? Well, here's an example where we did the eye care home tonometry. You can see that these patients, both patients here, have pressures of 12 in the office. But in one case, the peak pressure went to 24, and their pressure fluctuation at home was up to 25 to 30. That patient here needs surgery, but doesn't need a pressure of 8. They need a pressure of 12 to be consistent. On the other hand, this patient is progressing at pressures of 12, and even though we do water drinking test, even though we do home tonometry, the patient is still progressing despite not having high pressures, even beyond the office. Well, that patient needs to have a very low pressure. So for me, this is really the value of doing, for example, water drinking test, to get an idea in terms of, is this patient truly somebody progressing at low pressures, or somebody, on the other hand, who really is just fluctuating and having peaks. And we certainly see that when we do surgery, we can lower those peaks when we measure pressures at home. So please keep in mind, again, my first thing is, yeah, be uncomfortable. If you're somebody who measures pressure only once in the office and treats glaucoma, I think that that's not a good place to be. And you should be uncomfortable for me telling you this. And that's the purpose of me saying this here. And think about your patient and measure their pressures if you can, and think about the role of WDT. Okay, imaging visual fields. Yes.
Like before we go to the next point, I'm going to start asking some questions.
Yes, good idea.
So for the water drinking test, do you consider doing that in, how do you classify your patients? We don't have time to do that in every single patient that comes to our office. So is it for you at help when you're going to do the surgery? Is this a patient who needs 12, or is it a patient who needs single digits? Or is it just a rapid progression patients? How do you consider when to do that?
It's exactly the one you mentioned, where you have a patient progressing at normal pressures. And I'm not sure, like, why is the pressure normal and they're getting worse? If I do a WDT and they have a spike up there, then I'm not aiming for a pressure of 8, right? On the other hand, if they in fact are really not spiking and not peaking, then that patient does need a pressure that needs to be very low, and that will guide me in therapy. It also may be helpful for patients where I'm just not sure, they have a few risk factors. Should I be more aggressive in my treatment or not? Should I take the patient to surgery or not? Just like I look at corneal thickness, I look at family history, I look at the IOP pseudoexfoliation. That one who I'm kind of debating, do I need to be more aggressive or not? Maybe the OCT is showing some changes, maybe not. That's where I'll use it as an additional value to look at. But I agree. I mean, we can't do it for everybody. And so I select out those patients who I'm worried about. I'm not sure about their risk as much, or they are progressing, and I want to get a better idea as to what their risk is and how low do they need to go. So that's a very good point in terms of how I think about it.
I have a question, Do you think, do you correct all your patients' IOP with a corneal thickness?
No, I don't, because we don't have a way to correct for corneal thickness. I look at more as a risk factor. Someone has a thin cornea, well, that patient is at risk for progressing or converting to glaucoma. That's the only way I use it. I do not convert, and I don't think we have a good way to do it. So I don't do that. I do is corneal hysteresis, mind you, which is another way to look at corneal biomechanics, because certainly a thinner cornea, there's more to it than simply just IOP, change as far as the true IOP in the eye. So I don't convert it.
Okay, thanks.
Good questions though. So yeah, please interrupt me, and I'll move on to the next one though. Okay, and these are, I'm building up a bit. These are more rudimentary, but I hope they're important for everybody who sees glaucoma patients. Imaging and visual field. So those of you who see a new patient, and you say, okay, we'll do a visual field OCT now, we'll treat you and we'll follow you up in 6 months and 6 months again. To me, I think that's not the best way to get an idea about someone's glaucoma in the first 2 years. I think that there's been some pretty smart people out there, Bal Chahan and others, who have really talked about this, in that the true way to determine someone's risk of progression is to do frequent testing for the first 2 years. In other words, bring them back 3 times, even 4 times in the first year and the second year. I know it's more visits, it's potentially a problem with cost. I understand that. But as far as the true value of determining someone's progression risk, we need to do a number of tests to do this, because only 1 or 2 tests, if we do it per year, we will not be able to document progression for 4 or 5, 6 years. And it's worse if the patient's fluctuating. So we need to think about that. Also, it's amazing now when we see gray structure and functional relationships here. And here's just an example where you can see, in this example, we have superior RNFL loss present in the supratemporal quadrant of the RNFL bundle. You see flattening of it, and you see infranasal visual field loss. Here we have both superior and inferior RNFL bundles that have been depressed, and we have superior inferior loss as well. So the structure to function correlation is very valuable, and we should all be using this in our clinics. Where do we look for glaucoma? Is it at the optic nerve? Is it retinal nerve fiber layer? Is it macula? Well, we see good correlation in this example. Both eyes have inferior RNFL loss. They have rim thinning present inferiorly, and they have inferior macular ganglion cell loss. Remember, in the macula, we're looking at the ganglion cells and the inner plexiform layer to look for loss. And you can see the very, very good correlation between these. Let's also remember that when we look for progression, we can look for either events or trends. Events are when a point becomes abnormal, from normal to abnormal, while trends are basically looking at a series of points over time, and they measure a rate. Please remember, the first place to look for progression is typically looking at event analysis, because glaucoma is typically a focal disease. In order to look for changes, though, we need to look again for timing. And visual fields, like I said, suggestions are to do 3 visual fields at fixed intervals for the first year, do the same thing for the second year, and then assess them. If they're not progressing, we can then space out the visits, maybe once every year, maybe once every 6 months. On the other hand, if they are progressing fast, they need to be then, of course, treated more aggressively. And this for visual field testing, I think, is the modern way to do this, is to do frequent testing. And the same thing is for structural, like imaging. Doing 3 to 4 tests per year will have a greater chance of detecting small changes over the course of this patient's early follow-up. And so again, think about doing more frequent testing. Here's examples of OCT and visual fields. We see on the deviation map, we see pixels that become abnormal from normal. These are focal changes. These are called event changes. They went from normal to abnormal. Same thing with the profile on the TISNET profile. Superior, inferiorly, we see that the most recent scan has RNFL loss inferiorly. This is an event that's become abnormal. On the other hand, at the plots here, looking at the plots, at the regression analysis, we see these lines. We see the trend of RNFL loss over time. This shows us more how fast the patient's progressing, but this shows us more whether the patient is progressing. So please use both. Same thing on the visual field. We look on the right here. We have these points here that have changed to become abnormal. This is called an event that's changed. And here we have the trend that's getting worse. So trend is good for a rate, but it will not show early changes. On the other hand, event will show changes. So I realize these are sophisticated programs. It helps to have the right software. And I recommend, again, looking at these algorithms and looking at both the macula. Here, for example, we see superior macular changes, which is nicely correlating to the superior RNFL changes that are present on all of these plots. And again, we see visual field changes that nicely correlate in progression here with this patient inferiorly with the superior RNFL loss. So very valuable to follow patients. Even patients who have relatively normal visual fields can have significant RNFL loss, like here, for example. Here's an example of a patient who has maybe some early changes in their right eye. You see on the GPA analysis. So these points on the visual field have become from normal to abnormal from the baseline over, in this case, 4 years, 2012, 2016. But look at the event. Look at the VFI or the mean deviation plot. It hasn't changed. It's not significant. If we only look at this, we're going to miss progression. We need to look here. The left eye, again, on the trend, nothing here. On the event, maybe a couple of points, but nothing really to write home about. But this is where imaging nicely shows the same patient. We see corresponding inferior loss present here on the event and also on the trend, which is nice to be able to show this. So please make sure we look at both. They both are valuable. In fact, this particular patient actually ended up with pressures that were normal in the office, but look what we found when we took the patient's pressure at home. They were spiking up, and they were up, you see, up into the 20s. And that explains why the patient was getting worse. And having this information would be helpful. So again, on this point here, please frequently test patients. Try to use the best available imaging and structural and functional visual field analyses as well, and use correlation. And more, we're relying on imaging. For example, in COVID, we're not testing visual fields because of the concern with the bowl and the virus. We don't know how significant it is or not. But imaging can be done fast and can be cleaned easier. So we do rely on imaging more and more to detect. There are, of course, some artifacts that can occur, but I think we're doing it more frequently. So I'll stop here for a second, Vanessa and Maritza, if there's any questions about imaging and visual fields, or back to IOP.
Okay, I have a question. Do you always use 24/2 for glaucoma, or you sometimes use 10/2?
Yeah, great question. So this is a good example here where 24-2 I use, but when the visual field is becoming in the center, like here you see in this example, the follow-up exam, look at the visual field encroaching the fixation. Here I will want to get 10-2, but I still want 10-2 will be the most useful modality for patients who have advanced glaucoma. I should have mentioned this before, that OCT is great for early, but visual field is what we use for advanced glaucoma. And when it's close to fixation like this, I want to do a 10-2. So very valuable point. However, if I only switch to 10-2, I'm going to miss looking at the peripheral visual field inferiorly. So in this particular patient, I want to do 10-2 and 24-2, alternate them. I know it's lots of testing, but ideally that's what we want to do. But if I have to only choose one in this particular patient, I'd want to have a 10-2 because I'm very worried this patient is getting visual field defects close to fixation. So absolutely good point.
I'm going to jump in on the same note. I want to ask you, Ak. So again, out of your comfort zone, we don't have macular OCT. We don't have all this specific like trending study machines and all that. Would you consider using in your patient for the first time to create a baseline? Would you consider using a 10-2 as a baseline instead of a macular OCT to try to understand what's happening in the macula of that patient?
So I think certainly if the patient presents with advanced glaucoma, that's what they should start with. But I think you're talking about somebody who maybe has early glaucoma and you do 24-2. Well, you make a valuable point in that there are patients, for example, with early glaucoma who actually have central visual field defects. Their structural damage is occurring in the macular vulnerability zone, and that's causing them to have paracentral visual field loss. So yeah, I think, you know, that is important. In fact, the new visual field machines, the 24-2C, add central points to that. But of course, you have to have that machine. So I think it's good to get at least one 10-2 in the patient's first year, if you can, to get that central view. MAC OCT, if you have an OCT and you don't have MAC OCT, that's okay. In RNFL, will usually correlate to the macula. But the macula may show changes earlier for some patients, and the RNFL may show changes for other patients. So I do think that if you have an OCT, that an RNFL is sufficient. And if you have a macula OCT with it, it's even more valuable. So that's what I was saying. If you don't have OCT, then again, we have to use our clinical guidance using our clinical exam back to the nerve, back to looking at the fundus, which we should anyways, combining that with visual fields 10-2 and 24-2, as you mentioned.
Okay, and then the other question is the good old optic nerve head picture and aneurysma images of the RNFL. Do you see any value of that? Do you use that in your practice or?
Yeah, I mean, I think that unfortunately the art of fundus photography has gone down, although the technology has still remained. And I like to get a baseline optic nerve picture on everybody, because I think that's something that never changes, right? The OCT, we don't know what to make of it. The technology changes, but the appearance of the nerve will never change. So it's always great to do that. The reality is most offices, at least in North America, don't have fundus photography. They have OCT. And so it's just something that's not gotten. And in other places of the world, maybe it's different, right? So I think absolutely. And if you do that, do another one again in a year and in 2 years, and line them side by side. To me, I think it's most important to look at the fundus optic nerve color picture by looking at two pictures together. Looking at the screen, looking at the patient with your lens is not as good. You should still do that. But if you have the two pictures in front of you, you can actually look at them and go back and forth easier than looking at the patient and going back to the screen or back to the printout. So absolutely make use of it. Obviously, it requires much more clinical skill to look for change, and you need a bigger change to look at the nerve in order for you to document progression on an optic nerve. So yes, good point. Very useful point.
Ike, we have a questions about what do you prefer? Do you still use FDT matrix, or you use only Humphrey visual field?
You know, I primarily use Humphrey field analyzers or the like. I think FDT is great, by the way. I think it's great for screening. The FDT matrix, I should say, which is the second generation FDT, it tests 55 points on a 24-2. I think it covers great. It detects visual field changes before a regular HFA. That I think we can say, and it's similar to OCT at picking up early damage. My only problem with that is it's not so sensitive to look at small areas of progression, and the progression analysis is not really robust like it is on the CETA analysis, on HFA, on GPA analysis. So that's the only problem. For looking for progression, it's not so helpful. But for screening and detecting glaucoma, it absolutely is more valuable than a visual field, a regular visual field, which can be normal despite having damage to the nerve in the RNFL.
We have one more question in the chat. Thank you, Ike, for your support. This is from Luis Silva. Are you using Compass Visual Field Analyzer?
Luis Silva, another great Venezuelan. So Luis, stay safe. I know you're in New York, and I know you're helping in many different ways. So God bless you. Yeah, Luis, I mean, we have a compass, and I love compass. I don't have a slide on it for this presentation, but compass basically means it's like microperimetry for the peripheral visual field. So instead of a bowl, what the machine is doing is basically projecting light onto your retina. There's no need for a trial lens. It's projecting that light exactly to the retinal loci. And so therefore, by tracking the eye, we have better retest reproducibility, and we avoid fixation loss issues because we track the patient. I think it's great. I think it correlates reasonably well, not perfectly, to Humphreys. The reality is Humphreys are gold standard, so we have to always compare it to Humphreys. And then again, I will say the progression analysis is still in development. So we can get serial printouts, but to have the robust software like GPA analysis, which is really a pretty powerful engine to look for progression, is not what we have on the compass. Remember, progression analysis isn't just saying we have changes, but it's able to incorporate the variability of those test points and making sure they're consistent at each point that's progressing. So it's more than just saying we have point A, point B, point C that's changing. And that's where Zeiss, I will give them credit, and Octopus as well, and other companies have done a great job with that. So this will come, I think, in Compass as well, if it's not already available soon. Okay, great. We'll keep on moving here. So let me talk about target pressure. So here's my points. I think that target pressure is very arbitrary. I think that target pressure is basically a target that people manufacture. And who did it? Well, it's a group of experts got in a room together. Forgive me for saying this, but they are probably old white men with gray hair who basically decided that target pressure should be this, this, and this, right? Now things have changed, and I'm just making an exaggeration. I think the current guidelines are insufficient and impractical. I'll say it right now. I think we need to be more aggressive. I think that pressure measurements are random anyways, right? First of all, we're not measuring true IOP. The principle of measuring pressure through the cornea with a set, 3.14, millimeter size prism, and the Imber-Fick principle. I mean, we're using a lot of assumptions to measure pressure, which isn't actually accurate. Then, of course, we have pressures we're measuring only once, I mentioned earlier, and they're fluctuating everywhere. So I think that target pressure is really not, a science. And I think that because we are not able to really detect or know a patient's true pressure, I believe that the evidence is pointing we should be going low for everybody. I know it sounds aggressive, and it is aggressive, but I think if somebody is going to live long enough, I think that they're going to be better off with pressures that are going to be below 15 than higher. For example, our Canadian guidelines, what they will show is that people who have advanced glaucoma should be less than 15. If you have moderate glaucoma, less than 18, and mild glaucoma, less than 21. To me, this is insufficient. If you have glaucoma and you are 56 years old and you have this visual field in the middle here, I do not think you should be comfortable with your pressure being a 16. I think you should be telling your ophthalmologist, I want my pressure down to 12 or 13. Of course, there's risk in this and there's issues with adherence, but at least the principle of this, to me, is what I'm saying. We should not set target pressure because what is available. We should set target pressure on what's best for the patient, even if we cannot achieve it, in my opinion. We should know, the absolute truth is the absolute truth, and we need to basically stick to that. So this is my point. This is the European guidelines. You can see, for example, the similar mentality in early glaucoma, less than 21, in moderate, less than 18, in more advanced, go lower. And this is kind of a table from the guidelines. So this is kind of the problem, right? First of all, we base target pressure on these factors. So let me go number one, glaucoma damage, early or advanced. Well, how do we define glaucoma damage? Are we defining it by visual field? Well, by then the patient's already lost maybe half of their RNFL, and we're still calling them maybe early. So we underappreciate glaucoma damage, and I think it's not so easy to classify somebody with early or advanced glaucoma damage. Life expectancy. This is a valid point. Somebody who's 80 with early glaucoma, we are not going to be worried about blindness in that patient. I will agree with this. But somebody who's younger, it's hard to know. And even somebody who's older with moderate disease, I have patients living to 85, 90 years old. Does that mean somebody who's 78 years old who has moderate glaucoma we shouldn't be more aggressive for? We have to ask ourselves this question. Okay, next point. Untreated pressure. Is it high or low? Well, what is the untreated pressure? Do we really know it? Do we measure it in the office? Do we know the peak? Do we measure it at night? We're going to be guessing what the untreated pressure is. So you measure 18 in the office. But is it 18? Could it be 21? Could it be something else? This is part of the challenge with setting target pressure. And rate of progression, yes, I think it's important. As I said, by measuring rate of progression over 2-3 years, it's helpful to know whether this patient's at risk. But this takes time. This takes technology. And even with technology, it's not always easy to look at progression. The AAO guidelines talk about 25% reduction. And this has basically come from the EGF, from the EMGT study, which basically showed when you take a group of patients and you treat them with glaucoma, on average, 25% reduction, we lower the progression rate. But look at this. The patients who were treated, though, they still progressed. 60% of patients still progressed. To me, this is woefully inadequate. The excitement for the study should not be the fact that progression is lowered by treating patients. The highlight should be that whether we treat you or not, you still progress pretty badly. And why do they progress badly? Well, I think a lot of it has to do with our targets and how aggressive we are. Even early glaucoma, this is the UK glaucoma treatment study. Here, a group of patients with glaucoma, early glaucoma, remember early, not advanced, but early, had pressures that were treated with latanoprost or basically placebo. And untreated or treated, I should say, right? In blue is placebo, pressures didn't drop much. In red is it treated, they dropped, on average 4 millimeters. And yes, the progression at 24 months was less in the patients who were treated. But even the patients who were treated progressed. And remember, these are early glaucoma with a 20% drop in pressure. This patient would otherwise be fitting the guidelines that we typically talk about for early glaucoma. So my point here is that people still progress despite what I think is inadequate target pressures. And we do know that the lower we go with pressures, the more we can protect patients from progression. And we know from our Canadian glaucoma study that even people with early glaucoma, look at the average glaucoma here, -4. See, most people here on this call will agree. If you have advanced glaucoma, you should be low, down to 12. Most people won't disagree with me on this. But I'm telling you that forget advanced, even early glaucoma. Your patient would be better off in the long run, if they're going to live long enough, maybe they won't, that's a different story, with pressures that are going to be below 15, as an example on this particular study. So think about that for a second. I'm suggesting we need to lower our target pressures because I think we're not lowering them enough. Patients who have more moderate to advanced disease, yes, AGES study changed our behavior. It made us go from 21 to 18 to a lower target. Even that, I think, is not low enough, but you can see on average 12, we have a good level here. And we even see patients that may progress less when we do this. And if we do this earlier in the patient's treatment lifetime, the effect of our treatment can be more meaningful for a patient's lifetime. We can delay the onset to blindness if we treat earlier. So that's why I think earlier treatment is part of interventional glaucoma. So to me, the old school is stepwise therapy. Let's treat modestly and watch patients over time. With progression analysis that is not so great, that takes a long time to follow, and then we will react then. As opposed to, I think we should be more aggressive from the beginning. At least have a conversation with the patient. Should we aim lower? And should we address all these things properly? That's why I think that the numerical numbers we look at in the office, at least many years ago, was 21. We realized 21 was outdated. So we talked about 18. I think we need to talk about 15 or lower for all glaucoma. So this is my point. This point will make you uncomfortable me telling you this because it means you're going to be treating a lot of people more aggressively. But we have to do this in a way to address adherence. And this has been a big driver, by the way, for the new era of interventional glaucoma. So I'll stop here and let people attack me if you want. Go ahead. I don't mind.
We have two questions previously on the test that are in the chat. Maybe we should address those before we get into the target IOP, Maritza.
Okay, go ahead. You have a question?
Yeah, so one is from Sophia. She asks, what do you recommend for testing in patients under 18 years old?
Well, I still recommend imaging and visual fields if they can do them. Of course, the normative database is not valid for those patients, but in fact, the normative database is not valid for many patients over 18. The normative database consisted of people between 18 to 80 some years old for most patients, most platforms, about 300 patients with normal eyes. How often do we have the perfect normal eye that we image? Most people are not normal. So I'm not worried about not having normative database. What we're more important is looking for the pattern of RNFL. We're looking for progressive changes. So I love OCT in young patients if they can do them. And visual fields, yes, are harder to do. Visual fields are often normal in young patients, but OCT I think is valuable for that, for sure.
Okay, I have another one from David Goncalves. Fascinated with all your work. I have a question regarding the accuracy of the test. Are they accurate without being affected by age?
Well, aging does result in some changes in loss of retinal sensitivity, which is accounted for by the machine. That's why we always enter the age in our machine. We also know that on average, we lose about 0.5 microns of RNFL per year. So we have to think about that. But we're looking for progression rates that are much higher. For example, we're looking at 2 microns per year to be significant in some examples. So age is usually already corrected for in terms of trying to get an assessment for a patient's OCT. But remember, I don't like looking at the red or green. To me, that's not so important. What's more important is to look at the actual distribution of the change, to look at the curves, the Tisnet plots, and see whether the curves don't fit a pattern or are abnormal. Because many times you will see the OCT is in green, but they have glaucoma, or the OCT is in red, but they don't have glaucoma. Again, this is why we need to interpret these testing like a radiologist, look at very closely at each part of the scan, very detailed. It takes time to do that. But that's why, for me, age doesn't matter. I mean, I'm looking more at the other qualitative factors of the image.
Okay, we have one in Spanish. I'm going to translate from Elena Sanchez. She says, in a patient with chronic open-angle glaucoma, asymptomatic, recently diagnosed and has advanced stage. Patient is 42 years old. How long should we wait to get to the IOP of target under 15? And if we don't make it there within 1 to 2 months with medication, when do you decide to do surgery?
So I'm aggressive, but that doesn't mean I do it right away. I mean, I don't like to rush and do surgery on patients when I first meet them, because you need to develop a rapport, develop a relationship. So I will chat about the different options. I'll chat about where we want to be long-term, but usually I will not rush to surgery. And by the way, the Cochrane review and the NICE guidelines talk about people with advanced glaucoma going right to surgery, first line. I mean, the SIGA study, the Moorfield study, all show people with advanced glaucoma in the long run, even on first diagnosis, do better with surgery, trabeculectomy, than do with medications. But most of us don't practice this right away because, of course, you need to develop a relationship. But I will certainly, someone with advanced glaucoma who I can't get down to 12, 13, those patients I think have to be counseled to do surgery. It's going to depend on your comfort level with your surgery, your risk assessment. I'm fortunate I have advantages of using newer devices to create blebs, for example, like subconjunctival MIGS. For me, it makes me more aggressive. So part of the reason why I can be aggressive is because I have tools and available options to do it. But that being said, trabeculectomy is an art, and people can do a good trabeculectomy by paying attention to the right surgical technique and, more importantly, managing the postoperative course, which we'll speak about that later on.
Okay, Ike, we have another question. What is the sensibility and specificity about the eye care? And if you take some difference between the eye care home and the eye care you're using at the office?
There's been many studies on eye care, and what we really want to know is the level of agreement. How correlate or how close to does the eye care match up with the Goldman? Goldman is not the best gold standard, but it is our gold standard. On average pressures, the eye care will measure about 1 to 1.5 millimeters higher. That's the first point. Secondly, when the pressures are very high or very low, the eye care can be all over the place. We can't use it with reliability with very high pressures. But beyond that, there's generally pretty good level of agreement. Most of us are pretty happy with the agreement between and making a little bit of a correction factor between Goldman and eye care. And the same goes with eye care home. Eye care home, again, similar to eye care, I usually try to get patients to do it and test them out how well they're doing it. 25% of patients cannot do it at home because they just cannot hold it properly. But the others can do it. And I think that in those cases, they are reliable. We always try to match up, of course, in-office eye care with an in-office Goldman. So we can compare Goldman and eye care at the same time. But eye care really shines in examples, for example, during COVID, right? We can do it without anesthesia. We can do it and replace the probe without cleaning or cleaning the Goldman, for example. And we can have the patient go home and do it. In fact, patients can drive by. We can drive by and take their pressures with a handheld device, which is what's being done. Or we can mail you an eye care home and do it at home with the video instructions. So this is, I think for me, I'm comfortable enough with eye care. My bottom line.
Okay. There's another question. Which is the role of the Sensimed triggerfish in establishing the target IOP?
I don't think it's really valuable for target pressure, but there is some parameters that many have published, Gus Demoris and others from New York, Columbia, that there are certain values within the triggerfish that may imply someone's at risk for progression. So just like looking at fluctuation, if you see some positive findings on triggerfish, that patient may be at risk for progressing more than somebody who doesn't. The problem with triggerfish, it doesn't really measure IOP, it's measuring peripheral cornea. And there's so many values that we don't know what to make of them. And so to me, it's a very busy, confusing area. It's only 24 hours. And I did use it a few times, but I just haven't been able to employ it in my practice yet. That's my own personal opinion.
Okay. How low you think should be the IOP in patients with early glaucoma and IOP in 24 hours, I think? She's talking about the...
24 in a patient with early glaucoma. How low do you think? Is it still under 15?
If the patient is 75, 80 years old, I don't think you need to be aggressive. I think a nice 25% reduction, 30% reduction is okay, because that patient will progress. Yes, they will progress, but it's going to be slow. And by the time they progress, they're going to be really, really old and probably die. I shouldn't say that, but they probably will die. But if you're young and you're 50 years old, I would want to be less than 15, honestly, my personal opinion. Certainly, I would want to be in the lower than 18. But the guidelines, again, will talk about maybe pressures being, somewhere around 19 or 20. And to me, I think that's simply too high. So again, it depends. I mean, the time frame will, of course, dictate it a bit. A young patient, though, like, for example, under 70 years old, is going to live another 20 years. And that patient is going to progress if you keep their pressures, in my opinion, keep their pressures 18, 20. Remember, though, too, here's another point, too. When you lower the pressure lower, you reduce the peak. Right? This is an important point. So if the pressure is 18, you may be happy with it in the office, but outside the office, they probably are peaking to 21, 22, 23. But if the pressure is 14 in the office, their peak is probably going to be maybe 16, 17, 18. So this is another reason why I think lowering the pressure will lower the peak as well. The peak may not be known to you, but it'll lower that peak as well. Again, this is the ideal. Practically speaking, I understand. Patients may not tolerate medications. Maybe adherence is a problem. So you have to basically employ the practicality, but on a purist level, that's what I would say.
Okay, another question. Which one is your gold standard tonometer? I love Pascal and iCare, but routinely I use the Goldman, and in some cases I use the Pascal.
Yeah, we've used the Pascal. I think Pascal is great, but again, how do we use it in the context of our target pressures? I think is a bit of a question. So we still use Goldman because basically all of our studies, all of our data have been on Goldman. So we still use Goldman, but more and more, I think iCare for me has been something that I think is just more practical and I think reasonable enough. And because Goldman has a measurement error of 1 to 2 millimeters of mercury, if I tell Vanessa to measure my pressure, it'll be different every time by 1 to 2 millimeters of mercury. So even that error rate is something to think about when you think about other devices like iCare Home. We're getting basically a rough idea, right? IOP is by no means precise. We're talking about rough areas. Are you low? Are you medium? Are you high? And whether you're 16 or 18, whether you're 25 or 28, doesn't matter so much. It's more that area that you're in, to me.
Okay.
And juvenile glaucoma under 18 years old, surgical treatment is your option?
Yes, I mean, congenital glaucoma, juvenile glaucoma, for the most part, if the pressure is high, for the most part, it is a disease of surgery.
Okay, I think we are clear now.
So let me just talk about interventional glaucoma just for a short period here, because to me, this is kind of leads into the next couple of topics. Glaucoma is not the same for everybody, right? We have patients, to me, that are in need who have advanced glaucoma where we have high-risk surgery. We have to be better on that. And we have patients who have mild to moderate who are, I think, not best controlled, but more importantly, they have adherence problems, quality of life problems, and everything else. This is how we treat glaucoma right now, right? This is for all the residents and fellows right now. But what we do basically is this. In glaucoma, we have a false sense of security because we underappreciate glaucoma damage because we don't have good means to measure it. I think we're a bit lazy because we basically want to set pressure targets that are easy to obtain. We make excuses. Well, I don't have access to this, or my patient doesn't use this, or is that progression or not? You know what? Probably is a bad day, and that leads us into denial. And we get in this cycle until eventually someone gets so bad. Now we have a crisis now, and we have to treat this patient. And for me, that's why I think elevated pressure ideally is interventional. And this is kind of my mantra, as I said earlier: lower is better, earlier is better, safer is better, and we have to address adherence. And I think really for me, this is about changing our mentality. And again, keep in mind, I'm talking about a philosophy. I realize that we don't have access to all the technologies. I realize that you can't put people on 5 drops a day or 6 drops a day. I realize all that. But for me, I start with the absolute truth, and then I go into what is practical. And they may not match up. Practical is life. And so it's about being proactive and intervening earlier in disease, as I said earlier, and being more aggressive. And when we talk about key therapy options, right? This is how I do it. This is how I prepare myself in the OR. This is my yoga maneuvers in the OR, right? And I clean the floor too. But ask ourselves this: what should be our initial therapy? How do we escalate therapy? What is the definition of maximally tolerated medical therapy? What does MTMT truly mean? Where does laser trabeculoplasty fit? When do we go on to surgery? And what does this mean in the context of interventional glaucoma? Those are the kind of things that I think we need to address here. And we do have options now in many parts of the world with trabeculoplasty, sustained drug release. We have MIGS and we have microstenting blebs. These are 4 areas of which we have ability to address these topics. Trabeculoplasty. Okay, so we know trabeculoplasty lowers pressure better when the patients have higher pressures or they have their initial therapy. We know that trabeculoplasty lowers pressure in a similar level to prostaglandins. We know laser trabeculoplasty is very safe. And we now know trabeculoplasty is more cost effective, at least in some catheter systems. Trabeculoplasty addresses adherence and compliance, and it may be repeated. And we know now from studies that less patients who have trabeculoplasty compared to medications have to go on to filtering surgery. We also believe that SLT and ALT are similar, but SLT has less tissue damage, which may be important for repeatability and for future MIG surgeries. Okay, this study, I won't go in detail, the SLT life study basically nicely showed in a very, very well-designed study, randomized study, 3 years out, and convincingly showed that trabeculoplasty is safe, and trabeculoplasty is superior to medications. I will say this group of patients were mild and ocular hypertension. That's one thing to remember when we interpret the result of the study. And most patients were phakic, and most patients were not pseudosfoliation. You can see that SLT here, one treatment controlled the pressure in 75% of patients over 3 years. So you had SLT 360, and your pressure was controlled for 3 years in 3/4 of patients. 25% required a retreatment. And you can see that 80% of patients did not require medications at all, but 20% did. What's interesting is the number of patients who had to go under surgery. 0 patients, despite the pressures being the same between both groups. IOP is the same. More patients require trabeculectomy. Now, it's not a big number, 11, but 11 is still 11 trabeculectomies we saved by doing SLT, because less patients progressed when they had SLT done. We also know that SLT can be repeated. The repeatability is not necessarily as good as the initial therapy, but it can be repeated, and it can be repeated safely. So these are some of the points I want to mention. That think about SLT or ALT, if you have ALT, as first-line therapy. I think it addresses a lot of issues. We're seeing this more and more, even with MIG surgeries, that patients who have surgeries that lower medications, even though the IOP is the same, we find that the benefit is reducing the need to go on to further surgery, which is it's an important landmark in terms of the risk of more surgery. So I'll stop here and maybe take any questions people may have, or maybe not. On laser trabeculoplasty, I realize that YouTube is a bit behind us, right? So the questions may come in later.
Okay, I have one question. Do you use SLT like the first line of treatment before you use any eye drops in PYG patients?
Yes. And I've done it for I've offered it for many, many years. And I think finally we have studies to kind of support that. But I think it's something that should. Now, some patients will say, I don't want to have laser. That's fine. But I think for me, there's no question it should be offered and it should be preferred as first line.
And do you treat 360 or 180?
360.
360.
360,
yeah. Do you use
and
any eye drop pre-ops for SLT? Like, do you prepare your patients or?
I use brimonidine, and I put them on some non-steroidals after for just a few days. Many people do not even treat the patients with anything afterwards. I don't use steroids though.
Before you start the treatment in eye drop, is the SLT is no was enough for you? You treat again with SLT or you start with eye drops?
If somebody's had SLT already once?
Yes, once. And
yeah, if I do SLT once and it didn't work, I don't repeat it again. If it worked only for 2 months, I don't repeat it. But if it worked for a year, I will repeat it before going to drops. For sure, I would.
Okay. Vanessa?
Yeah, sorry, I was writing some tips for the chat. What do you do regarding SLT? Like, do you have any watch outs like for patients with pigmented dispersion or heavily pigmented angles? What are your watch outs? What are your recommendations? How do you handle? What are your parameters? What are your post-ops?
Yeah, it's a good point. I think people who have pigment dispersion, they're at risk for having IOP spikes. And so we usually lower our dose. We lower down to like 0.5 millijoules, and we only do maybe like 1 quadrant, 20 spots. Often they get a good response just with that. But if we do 360 at 1 millijoule, then we could get a big massive spike, and that's been reported as well. So that's one to be careful for. Anybody with a pigmented angle, lower your settings and do less. You can always do more later on, of course,
Okay, do you think in your experience the SLT when you treat patients, when the patient has eye drop, is less effective, is less efficient when you treat with SLT?
It's hard to prove that, because if you're on a drop, the pressure is probably lower. And people who have lower pressures, they don't respond as well to laser. The higher the pressure, the better they're going to respond to treatment. So it's hard to say that. There's some theoretical reason to think that may be true in prostaglandin and their effect on the trabecular meshwork. Maybe it reduces the effect on laser. I'm not convinced of that, though. I don't think that's a problem. The issue is more that once they're on all this treatment now, the pressures are now normal or 17, the result is not going to be as good as someone's pressure is 24, of course, starting off.
I want to make a comment there, because I happened to be in a conversation where Dr. Latina was discussing the LIGHT study. And he was he's very sure that patients who are on previous medications, especially or particularly prostaglandins, they do have a lesser effect, or the results after on SLT is much less. So,
well, the problem is how to prove it. I know Mark well. I know Mark presented a poster on this and showed that patients who had SLT after prostaglandins did not do as well as non-prostaglandins. The problem is that the pre-op pressure was lower, was different between the groups, right? So your baseline pressures are different, so your response is going to be different. So it's just hard to prove that. It may be true, but it's hard to prove that.
Okay, how many times do you perform laser trabeculoplasty before you perform a surgery? Well,
I think a couple of points. I think that I see sometimes people do like 6 SLTs on an eye. I think that's too much, really. I mean, if they have a couple of times you do it, I don't think doing it again is going to really buy you more. There are some patients of mine who SLT lasts for 3 or 4 years. I do it again. It lasts for 3 or 4 years. I'll do it again. That's really like, you know, a good example where maybe I'll continue it. But most of the time I don't. I think the problem is in the question that SLT before surgery, it's just not the best place to use it. The best place to use it, again, is to use it as initial therapy. If you're using it before surgery, there was a study that was published, I think it was by Mark Usich, I believe, and maybe and also from Duke, that showed that SLT is not effective. But those patients are patients who needed surgery. They were on 3-4 drops. The pressures were average in the mid-teens or high teens. And of course, SLT didn't do as well in those patients. So yes, you can try doing it. I think you can do it once and see if it helps you. But in those cases, the response is not as good though. So don't expect a really good response in patients who are already on medications, already are progressing, pressures already in the high teens. Then that patient's not going to do as well as somebody who's, again, with higher pressures without medications. Okay, let's talk about MIGS. So I think MIGS has been established as a safer option than typical traditional surgery, but I think we also agree that it's not as effective. We know it can be combined with phaco or standalone. I think it's got a role to lower pressure into the mid-teens and or reduce medications, because medications, of course, are part of the problem with our patients. And the nice thing about MIGS is I think it still maintains the ability to do bleb surgery later. And I think that's what can be done. One of the challenges with MIGS is that often people say it's too expensive. But I hope people have heard some of our talks recently we've given and others have given as well, that really it can be done with limited costs. Now, MIGS is a procedure defined by its safety and by recovery. It's defined by the ability to do the procedures with a safer option than regular surgery. And MIGS can fit, in my opinion, anywhere from earlier in disease to pre-advanced glaucoma or prior to major surgery like trabeculectomy. We can think about MIGS in the inflow of the eye, outflow of the eye, by looking at Schlemm's canal or suprachoroidal. And then we can think about more powerful MIGS procedures, if you want to call them MIGS, like subconjunctival MIGS. For the most part, MIGS basically is now based in the canal because we don't have a suprachoroidal option anymore. Maybe we will in the future, hopefully, but not anymore. So really, for all intents and purposes, we're talking about doing MIGS procedures in the canal. Although the old cyclodialysis cleft can also be considered that as well, but was less reliable. As I said before, MIGS typically are patients who are looking at pressure targets into the mid-teens. And there are a variety of options. I mean, there are so many options out there, it's hard to keep track of all of these possibilities. As you can see, though, we have options that basically can be stenting, which are, of course, cost more. We have options that involve dilating and options that involve cutting. And cutting could be by blades or by suture or by a needle. I think they all can lower pressure. Now, I do believe that stenting approaches do reduce the risk of bleeding and do have a faster recovery. That's the advantage of stenting. But the challenge for stenting, of course, is the cost involved. And I realize that that's a problem. And for those patients or people that don't have access to this stuff, we can always go to a non-implant cutting approach, which we'll talk about. But these are the way to think about it. Again, stenting, dilating, and also blading or cutting are all options that we think about. This is a busy slide, so don't read all of it. But what I'm showing here is MIGS on top and phaco MIGS below. Most procedures are going to lower pressure similarly with some range and lower medication similarly with some range. It's not fair to compare apples to apples, but basically we don't have enough data and head-to-head studies to compare them all. But if we're to line them up like this, you can see they're all generally pretty similar. So I'm going to make a few points to mention because those who are starting MIGS don't do MIGS either because they don't believe it, or they feel their patients don't need it, or they don't know how to do it. And as far as doing this procedure here itself, the most important thing is visualization and setting up. And so here we're tilting the microscope. We are turning the patient's head, as you can see. All of this is really important for the setup to do angle surgery. This will make our view optimal. And what I like to use is basically a classic gonio lens, nothing special, the old Swan-Jacob lens. And this is like relearning gonioscopy in the OR. Remember in medical school or residency, you're learning gonioscopy on the slit lamp, and you're pushing hard on the eye and you're causing artifact. Well, the same thing is the same thing with the learning curve with regards to intraoperative gonioscopy. Same kind of learning curve exists in order to do this. And so we need to make sure that we really address these issues properly. One of the big things to think about is what I call top down versus en face. Top down is like, for example, you're standing on the patient's cornea looking down into the angle. We don't want that. We lose the ability for perspective in terms of following the canal circumference. Instead, we want to be like a miniature person standing on the iris, looking right at the angle, and we call that en face, like it's right at your eye level, as opposed to looking down on somebody. And so that's important for positioning, rotating the patient's head or rotating the scope to make sure we have a good view. So pay attention to the view. I'll let this video play, but those of you that are starting to mix are going to have these problems. And there's many problems in this case. First of all, the view is not great. Bubbles in the anterior chamber. Lack of focus. You see we have the decentered view here present. Stria on the cornea by pushing on the cornea or on the wound. Blood on the surface of the cornea because the corneal incisions cause some bleeding, and now the blood is coming on the cornea. We also see again the lack of visibility, lack of clarity. The view is not centered. So this will happen to all of you when you start doing MIGS. So learn to do MIGS before doing it by tilting the patient's head and the scope for regular cataract surgery, and just practice your incision, practice your hand position with an instrument like a cannula, like a BSS syringe, and be sure to then view the angle properly. It's really important to do that. The other thing I do for beginners often is I inject vision blue, because vision blue can nicely stain a pale TM. And here we're showing the eye stent going in. You can see we really beautifully show the landing strip. We enter the angle appropriately angled here for the stent. And you can see I'm losing the meniscus here, but I have enough of a view here. And you see how the nice trypan blue stains the TM. And that's something that's helpful. Now, for many of you around the world who don't have access to these devices, the ab-internal trabeculotomy, or the GATT procedure, gonioscopic assisted transluminal trabeculotomy, can be done. These patients will have a higher risk of bleeding, so pay attention to holding anticoagulants and holding antiplatelet medications. Put the patient in reverse van Dellenberg. I like to do this to basically reduce the blood flow to the eye. And in my opinion, I don't think we need to do 360 treatment. I think 180 is enough. And we need more data to support this, but theoretically it is. And there's less bleeding with 180 than 360. We'll talk about this as well. A more advanced option is to use a catheter like this, the iTrack catheter. This is the pediatric case you can see, where it's important to think about the incision. So look at the incision we're making. The incision is angled and directed toward the nasal angle. This incision is very important to place the suture through and make it, in this case, in the supranasal quadrant, and angle it toward and direct it toward the nasal angle. Here we're using an MVR blade to make the goniotomy. It helps to have the suture or the catheter in the eye at this point, so I don't have to go back and put it in when the eye is tilted. And notice we make a slit movement, almost 1 clock hour, back and forth, and then push on the posterior lip to fish mouth it open. It's helpful to have a lot of viscoelastic in the eye and even add more at this point. So therefore we prevent bleeding. And using a micro tire, a little micro forcep or a VR forcep, we basically track the catheter all the way around or halfway around, depending on what we do. This catheter I can inject viscoelastic in. That's one of the advantages. It may be helpful, maybe not. And you can see how we go all the way around by pushing. Usually it's about 20 good pushes to get all the way around. In other words, about 10 to 12 to go halfway. So 10 to 12 for 180, 20, 25 for 360. And now you can see we're all the way around. We can grab the distal end and pull with the external portion with a tying forceps. And now we've done a complete 360 goniotomy. Again, I don't do this for adults. I do this mainly for kids, 360. For adults, I typically recommend 180. And you can see how the angle's nicely opened up. We have split open the trabecular meshwork. So We know the trabecular meshwork is a very safe place to drain. Hypotony prevented. But it also means we limit our ability to lower pressure. We can't typically get below 13, 14 millimeters of mercury in most people. So that's important to remember that. And technically, it's something to remember that. We assume, of course, that the distal outflow system is intact. If we think about the canal system here, we're basically accessing aqueous in the canal. We can't forget about the rest of the distal outflow system where the aqueous is going to. And we know that coming from the canal, there are a variety of different collector systems that come from this. This is an example showing one aqueous vein coming from the back wall of the canal. Our goal is to get aqueous directly into this vein. Most of these veins are located in the infranasal quadrant. So if we have to make a goniotomy or a trabeculotomy, it would be good to include some area in the infratemporal area, infranasal area. That's where most of the drainage occurs by these large veins in the eye. Again, there's some variability. And we also know that aqueous goes out segmentally. This is one reason why I think 180 is enough, because if we look at this graph here, once we get past 4 o'clock hours, the resistance in the system plateaus. It plateaus. You don't get much more effect by doing more of a goniotomy. So for this reason, I think it's useful to consider to do 180. What we need for this is we need 5-Prolene suture for GAT, an MVR blade or 25 gauge needle, a low temp cautery would be ideal, it can be reused, and a micro tire or something like this that can be used to grab the suture in the eye. Here, the low temp cautery is used to smoothen the tip and make a round nose. Make it about 1.5 times the size of the end of the suture, as you can see there. Pass the suture through the carefully designed incision that was angled toward the angle nasally, and then we tilt the patient's head. Then the goniotomy is made. In this case, you can see with a 25 gauge needle. It helps to have the needle on viscoelastic because then we can use it to inject in the eye if there's bleeding. There's that slit opening. Make sure it's big enough. I think it's good to make it about a clock hour. And I usually push down on it. And then we basically pass this catheter into the opening. And again, usually it's about 40 quick pushes or 20 long pushes. I'm usually doing longer pushes, so usually it's about 20. And once you get to the last 180, you'll find there's more resistance. That's a clue that you've gone past 180. Here we're going all the way around. And there you see the tip coming out into the anterior chamber. We'll grab the leading end, the distal end of the suture, come off with the gonial lens, and pull that suture outside to make a 360-degree goniotomy. But like I said, more and more what we're doing is we're doing a 180 treatment, which is basically making this incision, in this case, you can see, try to make it in the infranasal quadrant because that will help you. I usually do superior goniotomies because if you get bleeding, this prevents the blood from trapping the inferior goniotomy or trabeculotomy. 10 quick pushes. When you get resistance, you stop and then pull the suture, and the suture will stay in the canal actually, and regrasp it, of course, if you need to, and we do a 180 degrees goniotomy. This can be done again around the world, and we've had many great surgeons show great results doing this technique around the world. And I think it's highly recommended to consider it. At the end of the case, and this is just showing another procedure here, but end of the case here, and there you can see we're passing the suture all the way around the canal. And then this is just showing the suture ripping through the trabecular meshwork using another lens. At the end of the case, I like to evacuate the viscoelastic, and I like to leave about 1/3 of the anterior chamber with viscoelastic. One way to know how much we put in is to put air first. So now we know the eye is filled with air. We follow it up with viscoelastic. We actually see a nice meniscus between the air and the viscoelastic to show us we have about 1/3 of the AC filled. And that really helps us to prevent blood reflux. So hypotony is a problem, and bleeding, particularly 360, can be a real difficult thing to deal with postoperatively. I don't like it at all. I'd rather have the pressure to be high in the postoperative immediate period. We stop glaucoma medications. We stop the medications after surgery. They're on steroids. And we know, of course, that steroids can get a steroid response. We're always careful to taper the steroids quickly as needed. So that's basically what I want to share with you about GAT and MIGS. I'm happy to, again, take some questions on this as we come toward the latter part of our talk. A lot of controversy, I know, I'm sure, I hope.
Okay, how many days or weeks before the surgery you stop the anticoagulation medication?
Well, for MIGS, I don't always stop it. I mean, it's nice to stop it, but practically speaking, the patients are reluctant to stop it, so I don't always stop it. But if I were to stop it, I would stop it a couple weeks before. This can prevent early hypotony because the drugs are washed out of the system. But I don't think you have to stop it. I don't think it's a necessary thing to stop it with MIGS.
Vanessa?
Yeah, I just have two comments that I want to bring to Ike. This is from Marcos Busier, one of our glaucoma specialists in Venezuela. So he just wants to let you know that glaucoma is a public health issue in Venezuela. The majority of the patients are being treated by general ophthalmologists, not by glaucoma specialists. And this will puts us on a limit that we can only treat them medically and not surgically, as you are suggesting. The fact that they can have some kind of a target IOP in mind is very useful for them, so they have a guideline, but it's very important for us that they understand that target IOP is a dynamic and individualized number, and it changes.
Yeah, I would agree it changes when patients progress, and I certainly understand the limitations of surgery. So if one cannot do surgery, then you are limited to medications, and you have to live with what you have, which is completely reasonable and fine, like I said. But I still stand by saying that I think a lower pressure is still an ideal level. Remember, in life we have lots of ideals. We don't get the ideals many times. We don't hit the ideals, and that's okay. We have to then settle for something that's in the middle. It's a good compromise because of reasons for access or cost or abilities or technique or whatever it is. So I think that's completely reasonable. And I think it is true, target pressure is not always all for one. Although, like I said before, in general, I'd like to get lower than perhaps what the guidelines show. So it's just important to remember that first of all, if you want to go back to the basics, even diagnosing glaucoma, you're ahead. How many people have glaucoma and are missed in diagnosis? So I should even say that from the very beginning. The most important thing is to diagnose glaucoma, right? That's already more important than even treating a pressure to 12. Second thing is to treat a patient and follow the patient and help them to understand the reason for follow-up. That's a big achievement on its own, right? And that goes without saying. That has to be really stressed, the importance of that. And then thirdly, then you can basically target your aggressiveness with what you have available. So I think that, yeah, I certainly don't want to imply that go and rush and do all these surgeries. And many people don't do surgery who follow glaucoma, and that's completely understandable. And those patients are not going to have surgery, but maybe those patients should be followed properly, or maybe use the right medications to get their pressures at target. But understand that those patients may be undertreated, and they may have to be referred to surgery, and that's where you need to know the right time to refer.
Okay, from Luis Silva, are you still using first generation iStent? Or if so, are there any specific case where you prefer over the iStent inject?
We use both. I mean, I think part of it's for training. I think they both are reasonably similar. I think that there are differences in technique. The classic iStent is harder to learn for some people with the lateral motion to put it in. The inject has a shorter learning curve. However, the inject can be placed too deep or superficial and may not be as clear to know the implant's in the right position. So there's plus and minus of this, I think, and I think that for me, I'm comfortable with either one, and I'm more sure of myself perhaps to know I have the first generation in the canal. But for those that have not had a lot of experience, I think the second generation is good, and you can practice with it to know how much to push on the canal. And the new G2W, we call it, will, I think, solve some of the problems in terms of how much pressure to put on the canal. So that's just my quick answer to which ones do I use.
Do you know what the W stands for?
The W?
Yeah.
Wide.
Oh, okay. So going back to, again, Marco was here, he had 2 points that I wanted to get to you. So this kind of links, his second comment links to your point that you made, that the first thing is to diagnose glaucoma and to even do something about it. So he says, the philosophy of interventional glaucoma has been adapted in Venezuela by obligation. We have no choice. The possibility that the patient will not come back to follow up or will never show up again in your visit makes us treat patients just to be safe better than sorry. That's our reality. Might not be ideal, but we prefer to stop a medication later on once you know the patient maybe doesn't have glaucoma.
Yeah, I mean, that's a big debate, I guess, but I understand the situation there. But it does tell you the reason to think about trabeculoplasty, right? If you do laser, then you don't have to worry about adherence. Forget about patients coming back. Compliance and adherence is really bad. I don't know how it is in Venezuela, but I'm sure compliance, put your drops in every day, is not great.
Yes.
For that reason, that's why I know it's very controversial, but I really think that glaucoma, we have to be thinking beyond drops, because drops don't get in. I mean, we're fooling ourselves to think the drops are being used regularly, but laser we know is working. We have to take drug delivery out of the patient and put it in our hands. I know it's controversial again, but I think glaucoma, at least elevated pressure, is more surgical than not. And we need to train more general ophthalmologists and more surgeons to do, basic glaucoma surgery and to learn to do trabeculoplasty or get access to trabeculoplasty. In the absence of that, then you have to do your best you can with drops.
Okay. Michelle Pereiro say, what do you do when you are performing GAT and probe get stuck?
So it can happen when the suture gets stuck. It can either go deeper into the suprachoroidal space or hit a bifurcation. I usually go the other way around. And because I'm not doing 360 most of the time, I'm happy to do even 90 degrees on each side. So I can usually get 90 degrees at least to get done. And that's usually enough for me. So it's not usually a problem if you get stuck. Usually you get stuck as you go farther down the canal as you push the suture. So you can go both ways, left and right, and you can do 90 degrees on either side, and then you do 180 total.
Okay.
When the worst comes to worst, by the way, take your blade and use the blade to cut the canal, or a needle. The bang approach, bent angle needle goniotomy, as my former fellow Arsham Shabani has talked about, where you use a needle, put the needle in the canal and just cut, similar to a hook dual blade.
Okay, Vanessa?
I want to ask you, going back to the GAT versus ABC. So do you know, or what is your experience regarding results GAT versus using the actual catheter?
I think they're pretty similar, honestly. I think that the catheter is easier to use. I think the catheter, we inject viscoelastic, which may be some benefit, but we don't really have any good head-to-head studies. I think with the catheter by viscoelastic, we have less hyphema. We're putting viscoelastic inside the canal, inside the collector system, which is nice. And there's less chance of the suture, the catheter going suprachoroidal, because you can see it as you follow it. So, but there's a cost difference, right? That's a big difference. So I don't think it's such a big difference in the pressure lowering, though.
Okay, one person, Abraham Liera, say about what is the difference between GAT, Trabecton, and Cahook? Maybe you can tell us what about your results with the different three techniques.
Honestly, I mean, I don't have any head-to-head results. I think they're pretty similar, honestly. A Cahook dual blade you can do for 90 degrees. A trabectome or goniotome you can do for 90 degrees. A GAT you can do for 90, 180, or 360. Honestly, I think that they're all relatively similar. For a KDB, you have to be careful again how you put the blade inside the canal to make sure you get a good cut between the anterior and posterior leaflets. But I think, to me, they're similar. The differences may be, for example, the risk of PAS, the risk of hyphema formation, for example, can be one thing. So that's where there might be some differences. But again, we don't really have any good studies to compare them. I think if you have access to any of those, I think you're going to be a step ahead still.
Okay,
one more question.
Go ahead,
the G transscleral. How do you use it, and what are your thoughts regarding the subcycle laser or the G6 as a treatment for glaucoma?
Well, I think the mechanism by which it lowers pressure, I still believe is more of a coagulation and tissue alteration in the ciliary body. I think that it can be a procedure that is safer than using the G probe with the classical settings, but it's not without its risks in terms of inflammation and pupil changes, CME risk, and conjunctival changes. So to me, I'm not comfortable in my practice using it early in glaucoma. And I find the retreatment is often frequent. We have to retreat the patient after 6 months, after 9 months, after a year. And I think that the more you treat the patient, I think you're damaging the ciliary body. And I think that's a potential risk for patients who need further surgery and their outcomes along that one. So I think that's one point. At the same time, again, you have people who don't have access to surgery, and they can do the G probe, or they can do a micropulse. And again, in those situations, I think it's reasonable to consider. I think it can lower pressure. There may be some side effects, yes, but again, considering the alternative, it's an option. So again, for people who don't do surgery, if you have access to the G probe, cyclodiode, I think a slow coagulation is useful, meaning we use low energy, 12, 50 milliwatts, 4 seconds, slow burn. If you're using micropulse, then using micropulsing cyclotherapy, I think, is useful. Those, I think, can be a good option for patients or clinicians who don't do surgery. But in my practice, I usually reserve that procedure for patients who've had surgery already. They've had a bleb surgery and I need to go lower. The bleb isn't working as well. Then I do it then, or for painful eyes. But I think in a different setting, I may be using it much more because if I don't do surgery, or I don't have access to surgery, or follow-up is a problem, I definitely think it's useful. And I think people who do them, who more than me, can speak well to that. And for example, Latin America, there's been some good experiences. So yes, I think that is a good perspective to add to it. So thank you for adding that. So let's talk a little bit about bleb surgery. I want to talk about back to the bleb, because this is still going to be the most common surgery that people do around the world. And I want to make a few points. And I want to mention that again, the bleb is now not just a pressure lowering device or a procedure. It's a procedure that the patient is going to always have for the rest of their life. Everything we can do to make the bleb look better and behave better and reduce the risks are important. So we have a pretty elaborate system we use before we do bleb surgery. We make sure the eye is quiet. Here, I like to stop medications. So we, for example, stop glaucoma drops. We add steroids as needed, because I think without doing this, these conjunctivas are not in the best shape. I think that's very, very important. I can just briefly go through this video. I don't want to go through the whole video here. It's a long video, but you can show this is one of my fellows operating. One thing I want to show is tenons. I like to make sure that we identify tenons carefully and properly before doing dissection posteriorly. Because tenons, I want you to remember the word tenons. We all know it, but it can be your friend or your enemy. If you treat it poorly, it can be your enemy. If you treat it as a friend, it can be a positive thing for you. And so you'll see that we're carefully addressing by grabbing tenons. Tenons inserts at the limbus, but retracts posteriorly when you cut it. This is certainly important for some of the subcons MINX procedures. And for trabeculectomy, I have the same philosophy. So we grab tenons, and now we know that we can work underneath the space. Second thing is that I like to inject mitomycin rather than use sponges. And I inject it here under the tenons, into tenons, before I open it up, after I open tenons, because I feel this is more of a titrated dose rather than using sponges, which can be quite variable. And every so often you can risk about losing a sponge. So for me, this has been similar results. The bleb morphology is the same, if not better, than using sponges. That's my dose. Typically, I inject about 0.1 to 0.2 cc's if I'm doing it this technique. Second thing is, I make my scleral flap, and we don't cut the flap all the way to the limbus. We stop at the end of the blue zone, because we want to encourage posterior filtration. Here you can see the cut down here, down all the way to the sclera. That reminds me, I have to send this video out to somebody. I forgot, actually. I still have it. I want to narrate it. And you can see how we are now creating a posterior incision and then tunneling forward. The different ways to do it, I like to tunnel forward because I think it makes a nice smooth bed. It's important once we reach the blue zone, we have to angle up with our blade so we don't enter the anterior chamber. And always, I like to go into the clear cornea, as my fellow with Valentina is showing. Then we release the radial incisions. Now we have the nice flap formed. Enter the eye by making a paracentesis, but don't shallow the chamber. And then you can see I'm really telling my fellow where to put the sutures. Pre-place 2 sutures before making an entry in the eye so we can close the eye promptly. And we make a punch. I don't always do a neurodectomy, but if the iris does present itself, then I do. And in this case, we are showing we're doing a neurodectomy here. Probably safe to do it if you're not sure. Make a broad neurodectomy, tie the sutures, inject BSS in the eye, and then it's a slip knot. The slip knot I can tighten or loosen. So you can go online and look how to do a slip knot. There we go. We're tightening it here. And then when we close, to me, it's very important to bring tenons forward. See, we're bringing tenons. If I leave tenons and leave it back there, what happens is I leave a scar of tenons back here, and I have a very anterior cystic bleb that can form. Instead, by bringing tenons forward, we're allowing the bleb to form diffusely posterior and protecting from avascularity. And this is where mitomycin we can use with more dosing because we have the protection of tenons. So I don't typically do a tenectomy. Maybe I will do it for a very young Black patient. In that case, I'll do a very broad tenectomy, but most people I don't. And that's basically how we manage and how we do our blebs. I want to mention one point as well for needling. I'm someone who likes to needle a lot. You can see I use 0.5 milligrams of mitomycin, and I use a 27 or 25 gauge needle. I do it at the slit lamp. Like this is an example here. This patient has a scarred bleb.
Coming up here, all the way down.
Here, the slit lamp. I already checked. I made sure I wasn't swearing. Sometimes I'm saying bad words. This is mitomycin.
This thing here.
Under the conjunctiva. First. Usually I do this about 20 minutes before my needling. And this patient had surgery 5 years ago. Pressure was good. Pressure went up. You can't hear me? That patient I was saying.
Coming up here.
The patient I was saying was somebody who had tuberculosis 5 years ago, and then basically failed. Medications failed, and then they had a bleb needling. So let me just quickly show you the mitomycin injection.
Coming up here. You guys see the mitomycin injection there? I'll do it. Okay.
So after 20 minutes, hopefully you can hear me, Vanessa. After 20 minutes, we wait, and now here's the needling. Watch the needling with 27 gauge needle, entering the conj.
Straight down, way down as low as you can go. That's fantastic, right? Like that is great.
At the slit lamp, as you'll see here. And what I'm doing is I'm entering pretty posteriorly and coming down, pointing toward the flap. I look for the posterior edge of the flap, get my needle under the flap, and enter the eye through the flap.
Yeah, that's true too.
Get the tract.
So basically at the posterior edge right there, I'm going to aim down a bit. Now I'm in the flap, under the flap. I can let go of my other hand now. I can move my scope around. So can you guys tell I'm under the flap?
Yeah.
Okay, keep your head forward, Stephen. Keep your head forward. That's the way. That's the way.
Just go down.
First I'm into the AC.
I go into the anterior chamber, as you see there. Now we have the communication, and I go back and forth to cut the posterior edge of the flap, basically lifting the flap up. I think needling can be quite effective. Doesn't always work, but I'd probably say it's about 60-70% successful in my hands. I put some air in the AC afterwards, and I think it's a reasonable option if the bleb is failing. So do consider revisions in needling. I'm not going to talk about it, but basically we also have other options like subconjunctival MIGs, Zen, and pressure flow. And both these procedures create blebs, but they do them in a more controlled manner, either ab interno or ab externo. I think this is a new way to make a bleb, and I think it's a better way to make a bleb. And that's something, again, I realize that cost and access is an issue around the world, but I want to mention it. That's basically what we've been using primarily. So let me just quickly go through my algorithm. I have 4 different patients, combination cataract, those that are basically, I need a pressure of 12, those that need a pressure of single digits, and those that are standalone that our target is in the mid to high teens. So what about combination cataract? These patients, I typically think about doing combination cataract MIGs because I want something that's going to be safe. I want to avoid a bleb. I want to have a fast recovery, and I typically do stenting. On the other hand, if I'm looking at a standalone, not combined cataract surgery, I want to avoid a bleb. I want to have the greatest probability of pressure lowering, and I want to access a good collector system. And in this case, I do a trabeculotomy, like a GAT, for example, is something to consider. This is, again, standalone. If I'm doing a pressure of 12, I need to go bleb, but I'd like to do something more predictable, and we'll do a subconjunctival mixed procedure. But patients for me who need trabeculectomy are ones who really need low pressure, and those are the ones where typically I look to trabeculectomy. And that's basically how we typically use our different options available to us amongst these approaches. So that's basically bleb surgery. We probably don't have time to talk about tubes, but I'm happy to take more questions now as well, Vanessa. So I'll stop here and let the conversation continue.
A question, what is the biggest change you've done in your trap technique in the last 10 years?
My biggest thing has been tenons, managing tenons, number 1. Number 2, injecting mitomycin C rather than using sponges. And probably those are the 2 big ones. Number 3, I would say maybe the flap design. Maybe I don't got the flap so anterior anymore. I make it more posterior. That's probably the things I would say I changed in the last 10 years.
Okay, what's the rationale for not cornea?
Well, the reason for that is basically I want the flow to be posterior. And so by basically putting that flap more posterior here, for example, that means that the flow is going to be more posterior. If it comes too anterior, I'm going to get aqueous flow anterior near the limbus, more likely to leak as well. But I want to divert all that aqueous posteriorly. And that's why I think we don't need to cut all the way forward. I want to go this way and not come anteriorly. That's the rationale for me.
Okay, you use the mitomycin C for doing needling 20 minutes before the needling, yes?
Yeah.
Okay, and you use the same dose you use for the surgery, or you use less?
I use a higher dose because these patients have already had 0.4, for example. And so I'm going to go to 0.5 if they scarred up.
I want to ask you some questions about how you keep, how you can keep the mitomycin frozen for a long period, because we usually only mix and keep for 15 days and that's it. But when I stay with you, you show me you keep the mitomycin frozen for a long period.
Yeah, there's good studies to show it's very stable. If you basically start a mitomycin, for example, at 4 degrees and keep it down near frozen, that it can last for a year and you only lose 5% of your activity. So I think it's completely reasonable to do that. If you put it in the fridge, it'll be stable for a shorter time, maybe for a few weeks. I don't remember exactly how long that is. And you can make it new. Now, the problem is that, of course, some regulations have changed too around the world, and this makes it difficult to allow you to store it. But practically speaking, you know what? I mean, there's good studies that show it can be stable, freezing it and keeping it 4 degrees, for example. And then you take it out and you thaw it out for 1 hour before your surgery, before your needling, and use it.
Okay. You usually, when you do the trabeculectomy, you inject the mitomycin? Do you prefer that technique?
I do, yeah. As I showed, I used to do it before through the conjunctiva, like, right before. Now I open the conjunctiva and tenons and I inject it under tenons to show you that. I do that because I think the dissection is easier when you have not injected into the tissue. So I like to have virgin tissue, virgin conjunctiva, and just do my dissection, open everything up, and then inject the mitomycin. And I use lidocaine as well if I need to. I don't inject lidocaine into the conjunctiva externally. No. All that does is hydrate tenons. It makes tenons thicker. Then tenons is harder to dissect.
If you have any difference between the flap construction required between rectangular or triangular flap?
I don't think it matters. I mean, I think rectangular for me, it just encourages posterior flow. A triangle, maybe it's more lateral. I don't know, theoretically. So I use rectangular. It's a good debate. We should do a study on this.
Okay. Vanessa, you have another question?
Yeah, do you use wound modulators for scarring? They're asking. I guess yes, because of the MMC, but maybe talk about MMC versus 5FU. And what is your experience with Ologen?
Yeah, so post-operatively, I think 5FU, Avastin we do use if the bleb is very hyperemic or it looks like the fibrosis is occurring. I think those are good choices to use. Ologen, I think, is great. Again, there's a cost factor in there. I like to use it for my revision. If I'm doing a revision, I will open the conjunctiva, cut the scar tissue away, revise the area, put Ologen and mitomycin in the Ologen, and then close. And I think Ologen is great. Ologen works very well.
Okay, I have one question about gut. If you have a really blood in the anterior chamber and you can see anything, you have the option wash up with the BSS and start again with Helon or any viscoelastic with cohesive viscoelastic, or you prefer control the bleeding only with viscoelastic?
So this is during GAT, for example, right? So what I would do is I try to control it with viscoelastic first, but if it's a lot of blood, then you got to wash it out. Otherwise, it's a difficult view. Now, you can wash it out by using irrigation aspiration or by using BSS on a cannula and just irrigating the cannula in the anterior chamber and burping out the OVD viscoelastic and then putting more viscoelastic in. So I think those are all options. I mean, the goal is never to get there. The goal is to put enough viscoelastic in and do more viscoelastic if there's any amount of bleeding. When you do your goniotomy, put more viscoelastic after. As you're passing the suture around, if you want to stop, put more viscoelastic in the eye. Don't rush and do it and get a lot of bleeding, because that can be really messy. At the end of the case, again, as well, we want to clear the blood out. So I like to irrigate the wound, and I push in the posterior lip, irrigate the blood out, and put viscoelastic in the anterior chamber. And if I have lots of bleeding, I will put more viscoelastic in the anterior chamber. And I will have to see the patient back maybe in 4 or 5 hours, because the pressure is going to be higher. But you do not want to have bleeding at the end of the case. It's going to be a mess after the surgery. It's not fun. And the patient's recovery will be longer, and the patient's pressure will probably be higher. And they may get posterior synechial, peripheral anterior synechial, PAS.
Okay. Can you comment a little bit about your post-op management, the regimen, drops, DOC? When do you do laser suture lysis after your traps?
Yeah, I think DOC, or digital massage, is very useful as a diagnostic tool, just to see the potential for the bleb to form if the pressure is too high. I do tend to tie the sutures at the right tension. I don't tie them too tight, so I don't necessarily have to do lots of suture lysis. But if I do suture lysis, I think it should be done within the first 2-3 weeks. I don't usually do it in the first week, but in the second week, I will do it. But before doing it, I will push on the eye gently. And if the bleb shoots up really, really, really high, I will defer suture lysis and bring them back. But the key is bring them back soon. That's the problem with trabeculectomy. Part of the problem is you got to bring them back frequently, because if you miss the window to do suture lysis, the flap is scarred down. Then you do suture lysis and you don't get an effect, and then you have to needle the patient, or flap lift the patient, lift the flap with a needle. So that's basically my feeling for suture lysis. I don't typically tell patients to go home and do digital massage, especially early postoperatively. I think that can lead to hypotony and flat chambers. And I don't think that has a role for it long term. I see some patients, and they've been referred to me, and they've been doing digital massage for years. And I don't see the benefit of that. I think once you get past the mature bleb, then all that does is temporarily lower the pressure for a short time. The pressure goes back up again, and you just get fluctuations. The bleb doesn't work better long run if you do that, in my opinion. But in the early postoperative period, there is benefit in having some flow. It's just wouldn't do it early on for a trab. On the other hand, for Zen and for in focus or PreserFlow, I think there's a role for it, because you have control of flow through the lumen. And I think there might be a role for it in those cases. But in trabeculectomy, I usually reserve it for me as a clinician to do it in the office, to guide my therapy for which suture to cut and when to cut it.
What about steroids?
Yeah, a lot of steroids early on, lots of steroids. I will inject steroids at the time of surgery if I feel the patient's not going to be compliant. But I use Pret for it every 2 hours for the first week, QID for 3 weeks. I will decide at 1 month whether I can taper it down. If the eye looks pretty quiet, I'll taper it down by 1 drop every week. And by the second month, they're basically on 1 drop a day. And I may continue it on for another couple of months and then stop it. Sometimes too much steroid can be a problem, however, and can cause the bleb to become encapsulated, or like a big dome. And that can potentially be related, I think, to steroid use. So in that case, I would be careful to reduce the steroid. So yeah, being a blebologist and knowing how blebs look like and reacting to it, very important. But you have to follow these patients every week. For trabeculectomy, I don't think you can get away with not following them closely for the first month at least.
Okay, would you reasonable to use mitomycin C at the beginning of a bleb revision and then put your Ologen implant, thinking about aggressive scar blebs?
Yeah, what I do for revisions, I basically will do what I do for my conjunctiva, open it up. I will then remove the scar tissue. I will then inject mitomycin. And then I'll put Ologen on. I'll put mitomycin again on the Ologen. And then I close the conjunctiva. These patients need a lot of mitomycin. I mean, they've had previous scarring. And so I use mitomycin a couple of times like that.
Okay, there's a question from Abraham, who has sent many, many questions throughout the...
Abraham, what's up?
Yeah, thank you so much. How do you solve the problem of non-compatibility, I guess, with tubes and the endothelium? What is your vision on that?
Yeah, I mean, so first of all, tubes have been shown to cause endothelial damage, but trabeculectomy also has been shown to cause endothelial progressive damage. So any of these surgeries can cause progressive damage. For tubes, I think it's important to make sure the tube is placed well away from the cornea. And I like to make sure that the entry of the tube is basically at the level of the iris plane. I just show a quick video just to show where I enter. I enter right at the end of the blue zone, and that's going to be basically right at the above the iris insertion. And nowadays, we often do a scleral tunnel without using scleral graft material by going 3.5 millimeters posterior to the blue zone, about 4 from the limbus, as you see here. And I use a 22 gauge needle bent in a certain way, tracking along the sclera until we reach the blue zone. Once we reach the blue zone, I start angling down toward the iris. But I think keeping the tube short and keeping the tube away from the cornea, angled along the iris plane, is important to make sure that we don't hit toward the cornea. But it is something that we have to know. It's, again, risk-benefit. It's about taking the least risk, protecting the nerve, and risking the cornea. I always tell my cornea colleagues, we can always replace the cornea with the DSEC. We can't replace the nerve. And so in those cases, we have to take that chance. But I don't usually do tubes primarily. Like primarily, I think that we have good studies to show that primarily trabs do better than tubes, at least at 1 year. This is our PTV study. But in people that have previous surgery, they've had trabeculectomy surgery already, or they have bad conjunctiva, tubes are more successful than trabs. And when we talk about tubes, by the way, just to briefly talk about our studies, Ahmed versus Bearvelt, Ahmed's and Bearvelt's both lower pressure, but Bearvelt lowers pressure more. And success rate is better with Bearvelt. But what I do for my Ahmeds, by the way, I do aggressively treat them with hypotensive therapy. I'm adding all these pros in here just because I only have a few minutes left, I think, with you guys. But for my Ahmed valves, the problem with Ahmed valves is they get encapsulated like this. And I think it's because they get aqueous flow to the bleb. And if you reduce the aqueous flow by putting them back on medications for the first, from 1 week to 6 weeks, by keeping the aqueous flow down, I think these blebs end up maturing better. Don't use it from day one because they can get hypotony, but wait till the eye is pressurized to 12, 15 millimeters of mercury, and then add medications to get them and keep them at 10 or 12. And I think that's a better way to treat Ahmed valves than just put them in and only treat them when the pressure goes too high. By then, the bleb is encapsulated, and that's a problem.
I have to read one comment before we do the close down, Maritza. So this is from Fabiana Lopez in the chat. She says, my best friend is your biggest fan, Dr. Ahmed. I hope you can meet her soon.
Who's her best friend?
I don't know. It's a surprise, I guess.
Surprise. Well, be as persistent as Vanessa.
Be persistent. Be persistent. Send 100 emails and wait until he answers. No matter if he don't answer, you insist and persist and persist.
Well, I will say that, I mean, one thing with COVID is I have more time. So I've been able to be more in touch with people, meeting new people, you know, collaborating more and answering more messages and stuff. But that's only going to be for a short time. So I'm kidding. Yeah, I mean, I really want to thank you guys for the honor to be here. I know it's a lot of stuff. I'm sure it was controversial in some ways. I wish all of you around the world greatness and success and happiness. I particularly want to highlight my colleagues from Venezuela. I never had a chance to visit your country. I wanted to. I was invited, I think, before, but I wasn't able to make it. And it's my promise and my goal to visit Venezuela in one of these years. I always have had warmth from Venezuelans. Recently, when I was in a meeting in Colombia, meeting with some very great soul, spiritual Venezuelans, and of course, my closest Venezuelan I've ever worked with had been Vanessa for 1 year and more, continually to do that. So I really know, and I really value the you know, what you guys bring to the world. And although there are challenges, persevere, be persistent, and share your knowledge, share your warmth, and share your soul and your spirit, because that to me is more important than the knowledge or a paper or evidence or a surgical skill. The sharing of your spirit will guide people and give them passion to keep on learning and do more. So, Marissa, you have lots of energy. You share your energy to everybody around you and even through the internet. So keep up what you're doing as well. Alexander, thanks for writing. I've noticed all your comments. You're typing as I speak fast, and you've been writing furiously. So thank you for doing that. I don't speak Spanish very well, so you probably are saying things whatever I'm not saying. So don't believe Alexander. I'm kidding. Believe Alexander. And keep in touch. I hope we'll see some of you in Toronto sometime in the future as well.
Okay, I thank you, the Venezuelan Society for bring this space for us. Gracias al grupo de glaucoma por estar con nosotros el día de hoy. Y Alexander, hiciste un excelente trabajo. Muchísimas gracias por ayudarnos. Vanessa, muchísimas gracias por estar con nosotros hoy. A todos los miembros de la sociedad, and thank you so much. I thank you for staying with us tonight. And I will be there, okay? You can't escape from me. Bye. Thank you, everyone.
Have a good night. Everybody, love you. Take care.
Bye.
Thank you.